Hello everyone, I'm Anna Rajan and today I'm going to talk about air conduction testing in purotone audiometry. So when we say purotone audiometry, we are trying to calculate or estimate the threshold of a person using a pure tone stimulus. So what is a pure tone stimulus? A pure tone stimulus is a stimulus which has only one particular frequency, or it stimulates only the region of that particular frequency. When we say 1000 hertz, it will be in the critical band of 1000 hertz. That is a pure tone. So unlike a narrow band or a wide band noise or a tone which has a large spectrum, pure tones are a single frequency tones. So a pure tone has a frequency, amplitude, phase, and duration. Among this, the most important characteristics that what we need to know are frequency and amplitude. Frequency corresponds to the pitch of the tone and which is expressed in hertz, and amplitude corresponds to the intensity or how loud the sound is, and it is um, in terms of decibels. For a human, the normal hearing human or a range which a normal human can hear is between 20 to 20,000 hertz. But in that itself, 500 to 8 kilohertz is more sensitive, and most of our speech frequencies lie between 100 to 6,000 hertz. That's why we are doing the purotone audiometry covering all of this region, which is from 250 to 8,000 hertz. Okay, so among this, frequency and amplitude is the important component. When coming to calculations, these are just few formulas. So if you know the sensation level, when we say sensation level, it is like this person, uh, when the sound is this much loud, or that is a sensation level. So in order to calculate the sensation level, if you know the threshold of a person, you can subtract the level in which they heard the sound to the threshold. So how much of the sound is heard is the sensation level. So for example, I've given if the person's threshold is 10 dB and that person, we are presenting the sound at 30 dB HL, then how much sound has he heard is the sensation level. That will be threshold, like the dB HL minus the threshold. In this case, it is 20 dB SL. Similarly, if you want to know what is the hearing level when you know the sensation level, you can just add the sensation level to the threshold. If you take the same example of threshold 10 dB, if the sensation level is given as 20 dB SL, then if you add the threshold to the sensation level, sorry, the calculation is wrong. It is 30 dB HL. So 20 plus 30, 20 plus 10, it will be 30 dB HL, and that will be the hearing level, that will be the presentation level. So if you want to convert, if the sound pressure is given and the hearing level is given and you want to convert it into decibel, then you can do the log of sound pressure level by hearing level. And if you want to find out the sound pressure level, and if you know the pressure, how much of the sound pressure is present, then you can use the formula 20 log 10 P by P referral. That here the P is the pressure at that point and P referral is 20 micropascal. Why are we doing pure-tone thresholds? What is the need? One is to find out the type of hearing loss. We need to know what type of hearing loss this person is having, where the problem is. Is it in the outer ear or middle ear? So in order to find that out, we need the pure-tone threshold. Second is to figure out the frequency specific threshold so that we know at which particular frequency do they have an elevated threshold. That means that particular region in the auditory area is affected. When it comes to cochlea, the basal part of the cochlea has high frequency and the apex cords for the low frequency. So when a person is having a high frequency loss, we know that, or the high frequency region, if the threshold is elevated, we know that that particular person has some problem with the um, high frequency region or the basal part of the cochlea. So in order to get a frequency specific threshold, we can do pure tone threshold estimation. Then to find out degree of handicap, when we say do they have a mild hearing loss or a severe or a profound hearing loss, in order to figure out what is the degree of handicap, you can use the Pearson threshold. And when it comes to management, what type of management should we do? Do we need to do cochlear implant, or do we need to provide them with hearing aid? If the type of hearing loss is conductive hearing loss, then we can send them for medical management. So to determine what type of management has to be given, we can use the Pearson threshold. And to determine the candidacy of, for example, cochlear implantation, and to get a baseline, if you're going for a management, if you're going for a therapy or a treatment, you need to know what the baseline or where that patient lies. So in order to figure out the baseline, we can do a Pearson threshold. Then while giving a hearing aid, to set the frequency gain characteristics of that hearing aid, each frequency, how much of amplification, how much of gain is required, we need to do the Pearson threshold. And if you are doing some kind of management, in order to monitor the progress by comparing the baseline versus the current situation, you can do Pearson threshold estimation, and also for screening hearing loss. Then there are certain tuning fork tests. So when we say Pearson threshold or air conduction threshold, it's not always using an audiometry. So sometimes you can figure out whether the person is having a conductive or sensory neural hearing loss using a simple instrument, that is the tuning fork. So using tuning fork, what we are not calculating what is the threshold, or we are not trying to estimate what degree of hearing loss they have. Instead, we are trying to figure out whether they're having a conductive or a sensory neural hearing loss. You can do this tuning fork test as a standalone test, and also you can do this as a test along with the Pearson audiometry. So here what we are gonna do is like compare air conduction versus bone conduction. So two of those tuning fork tests which compare air conduction versus bone conduction are Weber and Rennie. In Weber, what we are basically doing is like we are checking for the lateralization. When we say lateralization, we're trying to figure out where the patient is hearing the tone louder. That is it in the right side or the left side, or is he hearing the tone in the midline? So when you are hearing louder in the right side, you feel that the tone comes from the right side, right? So for the Weber test, we place the bone conduction or the bone vibrators on the forehead, and then we present the tone and ask the patient or the client to determine where the sound came from. So if the patient is saying that he heard the sound in his poorer ear, that means he is having a conductive hearing loss, because when you're having conductive hearing loss, it is more of like an occlusion effect. When you close your ears and when you listen, you feel that some sounds a little louder. So when bone conduction comes, it sounds more louder because there is some kind of occlusion. So when the patient is saying that he is hearing the tone in the poorer ear, that means it is a conductive hearing loss. And if they are hearing the sound in the good ear, then the problem might be sensory neural hearing loss, because the other side cochlea is affected. That is why the person is hearing in the good ear. So the poorer ear might be having a sensory neural hearing loss. So this is how, using Weber test, we determine whether that particular ear is having a conductive or a sensory neural hearing loss. When it comes to Rinne test, here we are going to compare AC versus BC in a different way. So here we're gonna like use the tuning fork and place it near the ear canal and ask the patient to listen. And also we place it in the mastoid or in the teeth to give the bone conduction and ask the patient to listen. So if the patient is saying when the sound is coming through the bone conduction is louder, then they might be having a conductive hearing loss, because the cochlea is good. The bone conduction sound is better than the air conduction sound. Air conduction is getting lost somewhere because of the conductive component. And if they say AC is louder, then they might be having SNHL, because when you're presenting AC versus BC, there are not much amplification happening, right? Sound is directly going to the cochlea. But when it goes through the air conduction, there are some sort of modifications happening in the outer ear and middle ear. With that addition, it is going to the inner ear. So AC sounds better. So if they say that AC is louder than the bone conduction, then it should be SNHL. So these are two tuning factors which compares air conduction or bond conduction thresholds. When coming to purotone audiometry, we use an instrument called as audiometer to do the audiometry, and what we are doing is like we do the air conduction threshold, that is using an earphone, and we do the bond conduction threshold directly stimulating the cochlea, and then we compare the AC versus BC, and then we determine what type of hearing loss they have. So if AC is normal, that is the air conduction pathway going from the outer ear to the middle ear to the inner ear, then if that is the air conduction threshold, if it is normal and the bond conduction when you stimulate the cochlea directly is normal, then they might be having a normal hearing sensitivity. But if the AC is affected, the air conduction threshold is affected, but the bond conduction is normal, then their cochlea might be normal. So the problem lies somewhere between the outer or the middle ear. It can either be in the outer ear or in the middle ear or both outer and middle ear. So that means that person is having a conductive hearing loss. Now suppose if the AC is affected, the BC is also affected, but AC is almost similar to BC. That is like they are less than 10 dB gap, then that might indicate that they are having a sensory neurohearing loss, which means that their problem is in the cochlea. That's why when the sound goes through the air conduction pathway and bond conduction pathway, the threshold is almost similar. And if the AC is affected, BC is also affected. Sorry, AC and BC difference is greater than 10 dB. That means there is a difference between the air conduction and bond conduction threshold, but both are affected, then it can be a mixed hearing loss, which means that there is a problem in the cochlea. That's why BC is affected. AC is also affected, but on the way in the AC pathway, outer or middle ear is also affected. So AC will be much more lower than the bond conduction. That is because of the mixed component, conductive plus sensory neural. When it comes to the audiometer is the instrument that we use to calculate or that we use for estimating the audiometry. Audiometer has features where we can adjust the tone, that is, we can change the frequency of the tone from 125 hertz to 8 kilohertz, and if it has, we can extend it to higher frequencies too. And intensity we can vary from -10 to 120 decibels, and also we can switch between ears. You can present the tone to right ear alone or to the left ear alone, or you can present it bilaterally. And there are interrupter switches which you can manipulate that switch to present the stimulus. Usually in clinics, we use type 1 audiometer where you can present 125 Hz through 8 kHz for air conduction and 250 to 6000 Hz for bond conduction. And sometimes you can extend it to, like the air conduction can be extended to 12,000. And intensity level goes up to 120 dB. And there are different transducers. Transducers are devices which transfer one form of energy to another form. Here, in this case, we are presenting the electrical stimulus and it is getting converted to sound at the patient's level. So we have earphones, speakers, and bond vibrators. Earphones, we have three types of earphones. We have supraoral earphones. Supraoral are the one which just covers the pinna. So give me a second. So these are the supraoral earphones. It covers the pinna, and this model just sits in the ear. And circumoral has much more bigger cushions. So these are the ones which are used for high frequency audiometers. And then we have insert earphones. Insert earphones are the smaller ones, so it is very easy to use in infants or children. And also, this can be used in persons with collapsed ear canal because it sits in the canal. And hygiene wise, also, this is better because you can remove and use a new form for each patient. And also it has a greater interoral attenuation. That means if you present sound greater than, for example, 70 dB or 55 dB, then only it will go out of it. Okay, so as the size or the area of contact between the ear and the transducer reduces, they'll have a better interoral attenuation. That means you can present sound much more bigger. So even if you present a little sound, it will not cross over. That is the interoral attenuation. Then we have speakers. The speakers are used for sound field testing. You can't do ear specific testing, but you can check for localization or lateralization using the speakers, and also you can do aided, like with hearing aid, with cochlear implant testing. One thing that you have to remember while using the speakers are that you cannot use pure tones, because when pure tones are presented, it will go hit the wall and come back and forms a standing wave. So sometimes patient might not hear the tone properly. Instead of pure tone, you can use frequency modulated tones or verbal tones while testing using a speaker. And then we have bond vibrators. Bond vibrators are, it has a mechanical vibrator which vibrates our cochlea when placed in the mastoid. And based on the vibration, based on the frequency, there will be so many vibrations which is transferred. So it has very poor IA because you can't, again, bond conduction is not ear specific. The entire skull vibrates, and whichever cochlea is better, it picks up the sound first. Then coming to the test environment, audiometric testings are done in sound-treated chambers or sound-treated booths with very low background noise. We'll have carpeted or like sound-treated walls to reduce the reverberation time also. And we follow ANSI standard as 3.1 to set up the test environment. Before starting the test, we have to instruct the patient on how we are going to go about the testing, and make sure that you instruct the patient before placing the transducer. And what all instruction has to be given? The first thing is about the tone. You can describe the tone, what type of tone you're going to present, and ask them to respond to the tone, be it loud or soft. So whatever be the tone, they have to respond to the tone. That has to be understood. And then you have to give them a response task. A response task can either be to lift the hands or to press the interrupter. And in certain cases, when you doubt that there can be crossovers or cross hearing, then you can ask the patient to indicate the ear, like whether they've heard in the right side or in the left side. Okay. Then coming to transducer placement, when you are placing the transducer, it has to be done by the examiner to ensure that a correct placement is obtained. And in headphones or earphones, those are color coded. So right goes to the right side, means right is coded in red, left is coded in blue. So red goes to the right side, blue goes to the left side. And while placing, make sure that the patients, if there are any earrings or any jewelries or spectacles, anything which can prevent us from putting the headphone properly, you can ask them to remove those. And also ensure that the diaphragm of the headphone, if you're using a supra or a circum model, the diaphragm of the headphone has to sit straight with the ear canal, and the ear part of the headphones has to be with perpendicular with the floor. So it has to sit straight on the patient's head, and it has to be directly, diaphragm has to be directed to the ear canal. While placing mastoid has a part which vibrates, so that vibration plate has to be placed in the mastoid behind the ear, the bone, the protrusion where so you have to place that part in the master and then pull the other side and place the band somewhere in the opposite side, and make sure that it is sitting properly, and it should not touch the pinna because it can again get attenuated, or it should not be over the hair. So these things has to be taken care. Now coming to threshold estimation, we usually do psychoacoustical methods, and we do familiarization before task, like starting the test. So we started 1000 kilohertz because most of the energy, most people can hear 1000 hertz. So we start with 1000 hertz, and most, if the patient's better ear is known, start with better ear. And if you don't know which ear is better, then you can start with the right ear. And the tone is present for 1 to 2 seconds. And if the patient is having tinnitus, instead of giving pure tone, you can press pulse tone. And we mostly use modified Hugs and Westlake procedure. For that procedure, what we do is, like, you can look at the graph. We start at 30 dB HL. If they don't hear, we go up and suppose the person hears at 50 dBHL. So when they hear the tone at a particular level, you decrease the tone 10. So it's the 5 up, 10 down procedure. So if in this case, the person heard the tone at 50 dBHL. So I'm going to reduce it to another 10 dB. So it at 40 dBHL, he heard the tone again. So I went down another 10 dB, that is 30 dBHL. He heard the tone again. So I'm going down another 10 dB. Here he did not hear the tone. So when tone is not heard, we're going 5 dB up. So went to 25, not heard. Went up another 5 to 30, not heard. Went up another 10, 5, that is 35. So here the tone is heard again. So if the tone is heard, go down 10 dB and continue this until you get consecutively 3 times. If the tone is heard at a particular frequency, then that is considered the threshold. So this is a modified Hudson and Westlake procedure. So in this case, if you see 3 times, we've got um, threshold present at 35 dB, and the minimum level where you get this three times the 3 times response, then that is the threshold. So usually we start with 1000 hertz, go up till 8 kilohertz, that is 1000 hertz, 2000, 3000, 6000, and 8000. Come back to 1000 hertz to test whether whatever like responses what we've got is correct. Then go back like 500 to 50. This is how we track the threshold. And if between two frequency, for example 500 and 1000 hertz, there is a difference of more than 20 dB in threshold, then you'll have to do the mid frequencies, that is like 750 hertz, 1500 hertz. And if there is a greater difference between both the ears or air conduction versus bone conduction, then we'll have to do masking. For masking, you can refer to the video which is already posted on my page, in which I've explained masking in detail. Coming to the interpretation. So now we know the procedure, now we know the transducers, and we are familiar with the instrument. Now we are gonna interpret the results. So for that, these are the symbols that we use in audiometry. So for air conduction right, air conduction left, and if you're doing masking, what is the symbol? And if you're doing bone conduction or masked bone conduction, and if responses are not present, you have to put those arrows. So this is these are the basic symbols or legends that we use in audiometry. And for calculation of pure tone average is the value that we are going to calculate. So we are going to take the threshold value at 500 hertz. So for example, 500 hertz, the threshold is 10, and 1 kilohertz it is 10 again, and 2 kilohertz it's 10. Then we are going to take 10 plus 10 plus 10. So you're going to take the threshold at 500 hertz, 1000 hertz, 2000 hertz, and take the average, that is divided by 3. So that will be the threshold. And based on whatever pure tone average you're getting, you're going to divide or categorize it into what degree of handicap they have. So based on Goodman's standard, um, if they have threshold below 26, that is up to 25, then they are normal. And if they have 26 to 40 dB pure tone average, then mild. 41 to 55 it's moderate. 56 to 70 it is moderately severe. 71 to 90 it is severe, and 90 above is profound. So we use the term profound, and this is Goodman's classification. And then Clark's classification, that is up to 15 dB is considered normal, and 15 to 25 is considered a slight hearing loss. Okay, there are different classifications, and depending on where you are located, the classifications might vary. Then, so we got the type, like degree of loss. Now you have to find out what is the type of hearing loss. So based on the comparison between air conduction and bone conduction, we can determine whether the person is having conductive hearing loss, that is whether the outer ear, middle ear is affected, or it can be sensory or neural hearing loss, depending on cochlea or the auditory nerve is affected, and it can be mixed hearing loss. So based on the research, we will categorize it into conductive, SNHL, that is sensory neural hearing loss, or mixed hearing loss. Then there are different types of configurations. Based on the configurations, again, you can say what type of hearing loss. So here we have flat hearing loss. That is when there is less than 5 dB difference between each octave. So each of these are considered as octaves: 250, 500, 1K. So there's between these two octaves, if you have like less than 5 dB difference, then it is a flat audiogram. And then we have slopping. Slopping itself, we have different types. There are gradually slopping. That is when the difference is just 5 dB, 5 dB, 5 dB between each octave, or up to 5 dB difference, or 5 to 12 dB difference between each octaves. Then it is gradually slopping. If it is 15 to 20 dB difference between each octaves, then it is sharply slopping. And then we have precipitously slopping. This is precipitously slopping. A high frequency hearing loss is an example of precipitously slopping. That is, up to certain frequency, it will be kind of like flat. And then suddenly it starts dropping, like up to 20 or 25 dB difference between each octave. That is precipitously slopping. Then we have rising pattern. That is again similar to slopping. It is, but low frequency will be more affected than high frequency. So as you move from low to high frequency, there will be up to 5 dB difference between each, but it is improving. And then we have U-shaped or cookie bite pattern, or yeah, U-shaped pattern. So in this, mid frequencies will be more affected than the extremes. That is like the low frequency or the high frequency. And we have inverted U, which is an exact opposite of this, where the mid frequencies would be better than the extremes. And then we have notched. So this is an example of noise notch. That is like in one particular frequency, there will be a 20 dB difference from the adjacent one. So that looks like a notch. So these are the different types of hearing loss. Based on this, you can diagnose the patient. You can say that it is mild to moderate slopping loss, or you can say that high frequency HL, high frequency slopping hearing loss. And based on the configuration, again, you can interpret the results. Then again, based on all these factors, you can figure out whether the person is having a normal hearing, or sometimes they might have unilateral hearing loss, or they might have bilateral hearing loss where both the ears are affected. And bilateral hearing loss also can be two types. That is symmetrical, when both the ears have hearing loss, but it is almost in the similar level. Asymmetrical, when one ear is better than the other, even though both have hearing loss. Then while doing puretoneaudiometry, some cases when you know the case already, or when you're suspecting some of these diseases, you have to be a little cautious while doing puretoneaudiometry. When you see Carhart's notch is similar to like the notch which you saw in the previous slide. That is a bone conduction. When you're doing bone conduction threshold, you will see a notch at 2 kilohertz. So that is called as Carhart's notch, or somewhere between 1000 to 3000 hertz. So this is usually seen in patients with otosclerosis. And when you see a notch, you can suspect otosclerosis, but you'll have to correlate it with your other test results. And if somebody is having otitis media with effusion or a glue ear, then their bone conduction thresholds will be very, very good, because when they have this otitis media, there are chances that their outer ear is occluded. When occluded, or when there is occlusion, bone conduction sounds much more louder. So for these patients who have a otitis media with effusion or a glue ear, you might see a better bone conduction threshold. And if somebody comes with a complaint of pulse tone, when you're doing puretoneaudiometry, they might get confused with their tinnitus. So, sorry, if they have tinnitus, then you will have to use pulse tone instead of your pure tone for threshold estimation. And there'll be cases where that person might not actually have an issue, but they pretend to have an issue, either due to psychological factors or because of some other benefits. That is when you have functional hearing loss of pseudo hypoacusis. In that case, you have to be extra cautious while doing the testing. Okay. And for age-related hearing loss, that is the presbyacusis, the usual pattern that we see is a high-frequency sensory neurohearing loss. So when you see a precipitously sloping or a high frequency sensory neural hearing loss, and if the patient is aged, so you can correlate it to the cause by seeing the audiogram. And if a person is having an acoustic tumor or any kind of such lesions, then they might initially present with a unilateral hearing loss or a asymmetrical hearing loss. That is, one ear is better than the other. And mostly it is high frequency hearing loss, because when you see the auditory nerve, the outside part of the auditory nerve caught for the high frequency. That is why it gets affected first. So whenever you see a unilateral hearing loss or asymmetric hearing loss, you have to be extra cautious, consider it as a red flag, and make sure that you refer your patient for a medical examination. And then there is meniscus. When a person is having meniscus, you might initially see a rising type of audiogram, and later on it can become flat. Okay. And they will have other symptoms along with that. They might have oral fullness, they might have tinnitus. So along with these symptoms, if you see a rising pattern, that can be the early stages of meniscus. And if somebody is having a noise-induced hearing loss, you can see a 4 kilohertz notch, that is a dip at 4 kilohertz, or somewhere between that 3 to 6 kilohertz region. And if someone is taking a medication which is causing their hearing loss, then, or if you suspect ototoxicity, then it will be better to do the high frequency audiometry, because the initial regions that gets affected because of ototoxicity are the high frequency region. And if a patient has tympanic membrane perforation, when doing purotone audiometry, do not use inserts, instead use supraoral earphones. These are certain things that you have to keep in mind while doing purotone audiometry. And then there is automatic audiometry. So in the previous cases where we said in the like we have explained modified Hugs and Westlake procedure in that and all, the audiologist is the one who is manipulating the instrument. That is like the patient responds, we increase the tone, we decrease the tone. But in Becker's audiometry, what happens is like it is patient controlled. So when patient says that they heard the tone, it automatically goes down 5 dB, go down 10 dB. Okay. So this is automatic in the sense that it is controlled by the patient, or it's controlled by the response of the patient. You can present from 100 hertz to 10,000 hertz, and each octave is assessed in 1 minute. So in a minute, one octave will be tested, and they interpret the results by comparing the pulse and continuous tone. So this is all about purotone audiometry air conduction, and this is very basic, and I'll be talking about bone conduction testing in a upcoming video, and I'll also try to put a video on speech audiometry. There is already a video on masking, and if you want to refer, you can check that out. I hope these lessons are helping you out. If you have any doubts or any comments or any suggestions, please put it in the comment section. Thank you all.